Good afternoon, dear friends. I'm glad to continue our lectures, our webinars, and today it will be second part lectures concerning on interaction, drug-drug interaction, drug lenses interaction, drug devices interaction, drug disease interaction. Because when we analyze situation, we have now inter-situation when not just drug-drug interaction but drug-vaccine interaction and drug-device interaction can be reason of adverse reaction, plus because of morbidity and because one patient can has not one disease but many diseases, and it can be reason of polypharmacy. And polypharmacy because of drug interaction, drug disease interaction, drug device interaction, drug food interaction in this situation can appear adverse reaction, and in some cases it can be very serious adverse reaction. And don't forget, please, drug interaction not just drug for treatment but and drug for treatment and drug for diagnostic, and because for example contrast media drugs with beta-adrenal blocker can give as a result adverse reaction and bradycardia, and it can be anaphylactoid reaction, but like hiding bradycardia, it can be hiding symptoms like cardiogenetic shock. What I mean that it's not a simple anaphylactic reaction, but I make accent it can be anaphylactoid reaction. And why it's important? Because this massive, this this amount of knowledge we should resume, assume, and make from it as a result we should understand that safety of patient more important than every reason beside of safety of patient. What does this mean? We now have situation when as I see many drugs can appear now, and don't forget, for example, not just the risks from new drugs, but for example valproate and problems in pregnancy women who has been prescribed valproate, or for example hydrochlorothiazide and risk of non-melanoma cancer, and factor of risk in this situation can be long photosensitization. And plus, when we see it can be drug plus drug interaction, drug food interaction, and it means that it can be just make worse situation with safety of patient. The second part of these lectures will include pharmacodynamic drug interaction, drug interaction between drug and device, drug food, and drug lenses, drug disease. For our new participants, and I'm glad to see you, and I will be very happy if you will subscribe findability, will subscribe on my channel and YouTube, and for your future comments too. Let me introduce myself. My name is Galina Cordero. I'm a qualified person of pharmacovigilance, clinical expert, medical doctor with clinical expert and scientific background. Because of working in pharmaceutical field and combining knowledge with internal diseases, clinical deep knowledge, biochemistry knowledge, pathophysiology knowledge, pathology knowledge, I think it will be very important to start reflect this knowledge, and I decided to write a book concerning on this problem. And don't forget medication error problems too, and it will be topics of future lectures, plus direct interaction between separate groups of drugs. When we're talking about, we will keep going, and we will start talking about pharmacodynamic drug interaction. Pharmacodynamic drug-drug interaction can lead to addition of similar adverse reaction, for instance, anticholinergic effects of antidepressants and antihistamines. Pharmacodynamic drug interaction can affect receptor responses, for example, beta-blocking agents, and the increased risk of hypoglycemia and altered perception of symptoms of hypoglycemia using of oral glucose-lowering drugs. And as example of this situation, I can tell that, for example, interaction between not just beta blocking again, but for example T-octet acid, when which increasing affinity of receptors for insulin and for example hypoglycemic drugs, because of increasing affinity of receptor for insulin, this patient should be decreased level dose of insulin, because of again increasing affinity of receptor for insulin. Pharmacodynamic drug interaction can cause changes in physiological function, causing changes in effectiveness or excretion of other drugs. For example, nonsteroid anti-inflammatory drugs with the use of lithium, causing a decrease of renal clearance of lithium, resulting in lithium toxicity. In this way, pharmacodynamic interaction divided on direct pharmacodynamic interaction and indirect pharmacodynamic interaction. Direct pharmacodynamic interaction can be divided on antagonism, addition or summation, and synergism or potentiation. Direct pharmacodynamic interaction occurs when two drugs either act at the same site, for example antagonism or synergism, or act at two different sites with a similar end result. For example, naloxone reverses the effect of opiates, and vitamin K reverses the effect of warfarin. The anticoagulant effects of warfarin are increased in direct synergetic interaction with anabolic steroids and tetracyclines. Psychoactive drugs can interact with each other, potentiating their effects whether or not the two drugs have effects on the same receptors. For example, alcohol potentiated the action of other centrally acting drugs. The combination of alcohol with non-steroidal anti-inflammatory drugs increases the risk of gastrointestinal hemorrhage. Thus, 1 plus 1 will be 0. For example, the interaction drugs have opposite action. Examples can be acetylcholine and noradrenaline have opposite effects of heart rate. Addition or summation, 1 plus 1 will be 2. The interaction drugs have similar action and the resultant effect in the sum of individual drug responses. Example, central nervous system depressants like sedative and hypnotics. Synergism or potentiation, 1 plus 1 will be more than 2. It is an enhancement of action of one drug by another. Example, alcohol enhances the analgesic activity of aspirin. Indirect pharmacodynamic interaction, the object and the precipitant drugs have unrelated effects, but the latter and some way alters the effects, but latter and some way alters the effects of the former. Example, salicylates decrease the ability of the platelets to aggregate, thus impairing the homeostasis. If warfarin induces bleeding occurs. Pharmacodynamic interaction examples: excessive sedation, respiratory depression, motor incoordination due to concurrent administration, often, for example, benzodiazepine, diazepam, a sedating antihistaminic promethazine, or an neuroleptic chlorpromazine, an opioid morphine, or drinking alcoholic beverage while taking any of the above drugs. Excessive fall in BP and fainting due to concurrent administration, for example, alpha-1 adrenergic blockers, vasodilatators, ACE inhibitors, angiotensin inhibitors, high-saline diuretics, and cardiac depressants. Pronounced and asymptomatic hypoglycemia can occur when propranolol is administered to diabetics receiving insulin sulfonylureas. Pharmacodynamic interaction examples can be additive prolongation of prothrombin time and bleeding by administration of ceftriaxone or cefoperazone to a patient or an oral anticoagulant. Excessive platinum inhibition resulting in bleeding due to simultaneous use of aspirin, ticlopidine, clopidogrel, and carbamazepine. Increased risk of bleeding due to concurrent use of antiplatelet drugs, aspirin, clopidogrel, with anticoagulants, warfarin. Marked bradycardia due to administration of propranolol in digitalized patient. Precipitous fall in BP and myocardial ischemia due to use of sildenafil by patient receiving organic nitrates, because nitrates increase generation of GMP, while sildenafil prevents its degradation by inhibiting PDA5. Pharmacodynamic interaction and other examples and can be severe hyperkalemia by concurrent use of ICA inhibitors and K+ sparing diuretics. Additive ototoxicity due to use of aminoglycoside antibiotic in a patient receiving furosemide. Antagonism of bacterial action of beta-lactam antibiotic by combining it with a bacteriostatic drug like tetracycline, erythromycin, or clindamycin. Mutual antagonism of antibacterial action of macrolides, clindamycin, and chloramphenicol due to interference with each other's binded to the bacterial 50S ribosome. Reduction in antihypertensive action of clonidine by chlorpromazine and imipramine, possible due to blockade of central action of clonidine. Attenuation of antihypertensive effect of IC inhibitors, beta blockers, diuretics by nesteroids due to inhibition of renal PG synthesis. Blunted of CAP1 conversion action of spironolactone by aspirin because it inhibits the tubular secretion of canrenone, an active metabolite of spironolactone. Blockade of anti-Parkinsonian action of levodopa by neuroleptics and metoclopramide having antidopaminergic actions. Indirect pharmacodynamic interaction. Indirect pharmacodynamic interactions occur when one drug affects the pharmacological, therapeutic, or toxic effects of another drug, but the two effects are independent. For example, the effects of anticoagulants can be increased by three indirect effects: reduced platelet aggregation by salicylitis, dipyridamole, carbidopa, and non-steroidal anti-inflammatory drugs; gastrointestinal ulceration due, for example, to non-steroidal inflammatory drugs; and increased fibrinolysis due to, for example, to metformin. Diuretic-induced alteration in fluid and electrolyte balance, especially potassium, increase the effects of cardioleucosides and the class of 1 antiarrhythmic drugs, for example, lidocaine, quinidine, flecainidine, and phenytoin. Example: drug-drug interaction, for example, it can be angiotensin converting enzyme inhibitors with non-steroidal anti-inflammatory drugs. Hyperkalemia, decline in renal function, can be as a potential outcome of the drug-drug interaction. Ciprofloxacin, olanzapine. Ciprofloxacin inhibits cytochrome 1A2. As a result of the plasma concentration on olanzapine increases. Digoxin furosemide. Hypokalemia may increase risk for digitalis intoxication. Nitroglycerin sildenafil increased risk of severe hypotension. Spironolactone, potassium chloride, hyperkalemia. Verapamil and atenolol, bradycardia and hypotension. Warfarin and acetylsalicylic acid increased risk of bleeding. We see too many potential drug-drug interaction with prescription medication, and you see how many it, and I just pay you attention on this potential DDC is a lot. And in the end of my lecture I will show you drug checker site when you can check this drug can have this drug-drug interaction with this group or no. Common drug-drug interaction in psychiatry, you see that too many groups, you see outcome, you should remember it, and I make accent for psychiatry: serotonin syndrome, anticholinergic toxicity, QT interval prolongation, increased risk for seizures, increased risk of bleeding, decreased efficacy of oncology medication, decrease in antipsychotic plasma concentration, decreased efficacy of oral contraceptives, and decreased analgesic efficacy, lithium toxicity, and you see that it can be involved and cytochrome system and can be pharmacodynamic activity, pharmacokinetic activity. What I mean that psychiatry should know it. Drug interaction, and don't forget about drug disease interaction, because psychiatry patient can have not just psychiatric disorders. Drug associated with moderate QTS prolongation. This group and drug category analgesics, antiarrhythmics, antidepressants, antiemetics, antimicrobials, psychotropics, serotonin agonists. And you see that these drugs can be higher risk drugs listed in bold. And what groups? For example, analgesics is methadone, antiarrhythmics can be amiodarone, dofetidine, ticagrelin, procainamide, quinidine, sotalol, beta-pas, antidepressant, and very wide prescribed by psychiatry is Prozac. I pay attention that the result of, for example, using this group can be QTC prolongation, and it's very important directly and precisely for patient with cardiac problems. Please remember it. Drug lab taste interaction can have place too, and it can be appear, for example, using prescribing allopurinol. It can be increased serum bilirubin level, aspirin, iron deficiency, anemia, false negative value, and you see that, for example, from a memory, it can be insulin, a beta deficiency anemia, and you should remember it too. Lasix hyperglycemia, false positive due to hyperkalemia that decreases insulin production in the body. Glucocorticoids, postprandial hyperglycemia, false positive, so the drug should not be taken prior the test. Ibuprofen decrease urinary creatinine clearance, so test is done at least 6 hours after ibuprofen administration. Reducing the risk of drug interaction, identify the patient risk factors, take thorough drug history, big knowledge about the action of the drugs being used, consider therapeutic alternatives, avoid complex therapeutic regimens when possible. Examples of drugs with high risk interaction: concentration-dependent toxicity, dioxin, lithium, aminoglycosides, warfarin, cytotoxic agents, still dose response curve, verapamil, sulfonylureas, and levodopa. Examples of drugs with high risk of interaction can include patient-independent therapeutic effect, immunosuppressives, cyclosporin, tacrolimus, glucocorticoids, oral contraceptives, antiepileptic, antiarrhythmic, antipsychotic, antiretrovirals, saturable hepatic metabolism, phenytoin, and theophylline. Drug interaction with contact lenses. A number of drugs can enter into surface interaction with plastic contact lenses. For example, permanent damaging coloration of contact lenses has been reported with the use of rifampicin, and this is not entirely surprising since the antibiotic is known to cause reddish discoloration of tears, urine, and sputum. It has also long been known that fluorescein statins solve lenses and may permanently spoil them. For example, rose Bengal is also contraindicated. Also, the concentrating dye may be removed from the lens material by repeating leaching process. Adrenochrome pigmentation associated with the use of adrenaline eye drops has been reported to cause a dense brown coloration of the tints. Sulfasalazine used in treatment of colitis has been implicated in the yellow staining of soft contact lenses. It is now commonplace for those patients undergoing topical treatment with the eye drops and who also wear invertible lenses to be advised to remove their lenses for the duration of the treatment. It is more difficult, however, to predict possible interaction in those patients undergoing systemic therapy, and it is only through isolated reports in the literature that patients can be warned of this possibility. Generally, little predictive work has been done of this type of interaction. Drug-food interaction. It's another page of drug interaction. Another type of drug interaction. Drug-food interaction. The food is the precipitant. The interaction of many drugs with grapefruit juice, an inhibitor of cytochrome 3A4, glycoprotein, an organic anion-transported polypeptides is the best known example. Potential drug-herb can be and drug-food interaction. You see how many interactions can be. It can be buprenorphine, codeine, dihydrocodeine, fentanyl, and result of it, hydrocodone, hydromorphone, petidine, methadone, and you see morphine, oxidone, oxymorphone, tamantadent, tramadol, and types of interaction. Drug-device interaction uncommon. A good example of interaction if the device is precipitant, the risk of angioedema and anaphylactoid is known. Immunoglobulin E mediated anaphylactic reaction to ICH inhibitors, angiotensin converting enzyme inhibitor in patients undergoing hemodialysis associated with dialysis in which the membranes is made for polyacrylonitrile, also known as 69. The mechanism may be related to release of bradykinin. In other interactions, the drug in the precipitant is nitrous oxide, which is highly soluble, diffuses in the cuffs of endotracheal tubes and can increase cuff pressure, sometimes causing rupture during nitric oxide anesthesia. Erosion surgical measure more likely in women using estrogen. Example medication error involves devices. You should remember, for example, and one of regulatory authority of CIS country, Armenia, paid attention that the result of interaction between glycine and calcium gluconate because of appearing aluminum in solution increased toxicity of calcium gluconate. Example of medication errors involving devices. Patient received 100 overdose and diet as a result of insulin product being measured and administered using a 2 ml intravenous syringe instead of insulin syringe. Patient receiving 5 million dose of oral antibiotic syrup intravenously as a result of the dose being measured and administered using 5 milliliter intravenous syringe instead of oral and enteral syringe. Patient receiving subcutaneous injection of adrenaline into the thumb rather than into the required site of administration due to confusion over how to operate and prefilled syringe device. A patient did not receive the required palliative care analgesic subcutaneous infusion for 6 hours. As a result of nurse not correctly operated the syringe driver and setting a rate of infusion of 1180 ml over 20 hours. Another example can be a pediatric patient receiving an overdose of infusion fluid as a result of an adult intravenous administration set being used instead of pediatric administration and be it used where 20 drops is 1 milliliter instead 60 drops 1 milliliter, and the wrong rate of administration was set by gravity infusion. A patient became hypoglycemic and died as a result of receiving treatment for hyperkalemia when insulin infusion was administered by syringe driver and the glucose at 10% infusion that should have been administered at the same time was turned off by accident. An overdose of vasopressor infusion occurred as a result of volumetric infusion pump being misprogrammed and 100 ml/hour instead of 10 ml per hour. Examples of medication errors involved devices can be 30 ml syringe was used, a syringe driver pump instead of 50 ml syringe resulting in an overdose of vasodilator infusion. The patient blood pressure failed to be controlled adequately as a result of a normal intravenous administration had been used in the volumetric infusion pump instead of a low absorption that recommended by manufacturer. A patient experienced several phlebitis is inflammation of veins as a result of the intravenous antifungal infusion not being administration via filter as recommended by the manufacturer. A patient with obstructive airways disease being treated with a nebulized beta agonist went into respiratory failure as a result of the nebulizer device used to administer his therapy being powered 1198 by oxygen gas rather than medical air. A patient with obstructive airways disease being treated with oxygen therapy went into respiratory 1200 failure because of ventral mask delivering the wrong percentage of oxygen was used. Drug-food interaction. One of the early observations was reduced. We talked previously about interaction drug and grapefruit juice, and another one of the early observations was reduced absorption of tetracycline when taken with milk products. The chelation of tetracycline by calcium prevents it from being absorbed from the intestines. Dietary sources with vitamin K, such as spinach or broccoli, may increase the dosage requirement of warfarin by pharmacodynamic antagonism of its effect. Patients should be counseled to maintain a consistent diet during warfarin therapy. Grapefruit juice contains ibiflavonoids that inhibit cytochrome 3,8 and blocks the metabolism of many drugs. This was first described by felodipine Plendil, but has now been observed with several drugs. The interaction can lead to reduced clearance and higher blood levels when the drugs are taken simultaneously with grapefruit juice. With regular consumption, grapefruit juice also reduces the expression not just of cytochrome 3,8 in the GI tract. Grapefruit juice inhibits cytochrome 3,8,4, increased levels of antidepressants, sertraline, benzodiazepine, and verapamil. Drug-food interaction. Drug interaction, garlic with food the garlic when combined with diabetes medication could cause dangerous decreasing in blood sugar level. You can imagine situation, for example, diabetic patient, teoxide acid, for example, for improving metabolism and the condition of vessels, and combine it with garlic plus insulin, and in this situation there is a higher risk of hypoglycemia if endocrinologists will not pay attention on possible drug-food interaction. Some garlic-sensitive individuals may experience heartburn and flatulence. Garlic also has anti-clotting properties interaction with anticoagulants. Orange juice must not be consumed with antacids containing aluminum. The juice increases the absorption of aluminum and leads to severe constipation. Milk contains elements like magnesium and calcium which chelate antibiotics like tetracycline and hence decrease the absorption and effect. Vitamin K-rich foods reduce the effectiveness of anticoagulants such as warfarin, increasing the risk of clotting. Fiber in oatmeal and other cereals when consumed in large amounts can interfere with absorption of dioxin. And for example, alcohol beverages tend to increase the depressive effects of medications such as benzodiazepines, antihistamines, antidepressants, antipsychotics, muscle relaxants, and narcotics. Disulfiram like reaction with metronidazole. Increase metabolism of warfarin and phenytoin. Smoking increases activity of drug metabolized enzyme in the liver. It can be diazepam, theophylline, olanzapine are metabolized rapidly and their effect is decreased. Evaluation of specific drug interaction can be this way. You can ask question: what is the time course of the interaction? Immediately or over a period of time, is a drug's class effect, for example, omeprazole, lansoprazole, the interaction clinical significant. For example, it can be a therapeutic index of drugs, narrow or wide. How should the interaction be managed? DC drugs, switch to another drugs, or change dose. Drug disease interaction. Drug disease interaction can be when drug condition interaction occurs when a drug worsens or exacerbates an existing medical condition. For example, it can be nasal decongestants in hypertension, nonsteroid anti-inflammatory drugs, asthmatic patients, minoxidil, heart failure, calcium channel blocker, high failure, nicotine, high blood pressure, beta blockers, heart failure, metformin, heart failure. What you see as an example, for example, nasal decongestants plus hypertension, it increases blood pressure. Nonsteroid anti-inflammatory drugs, asthmatic plus asthmatic patient, airway obstruction, worsening condition of patient. Minoxidil plus heart failure, fluid retention. Calcium channel blocker plus heart failure is negative inotropic activity. Nicotine plus higher blood pressure, increasing heart rate. Beta blockers plus heart failure worsen asthma, and metformin plus heart failure increased lactic acid. Predicting drug interaction using, for example, CIP cytochrome phenotypes. Probe plus putative inhibitor or inducer. Measure probe plus minus metabolites concentration, radius of metabolized parent component. Examples of CIS probes: cytochrome 1A2, caffeine, cytochrome 2CD, tolbutamine, warfarin plus vitamin K. Cytochrome C19, simethicone, omeprazole. Cytochrome 2A1, chlorhexazone. Cytochrome 2D6, dextrometorphan, debrisoquine, spartane. Cytochrome 3A4, midazolam. Cytochrome 3A4, erythromycin. New approaches to check interaction. You see what I said before and pay your attention now. It's drug checker site, drug checking software. It can be drug.com, drug interaction. You see site and reference of it. Reference Medscape.com, drug interaction checker Medscape, interaction checker WebMD, unhealthy library drug reference drug interaction check, United Kingdom healthcare drug interaction checker, and Desktop.India.com, Drugster ISPS, Doctor Desktop medical practice software. It's Indian resource. Managing drug interaction. What you should do as a physician, healthcare professional, pharmacologist, pharmacist, pharmacovigilance specialist, professional. Comparison medication reviewed, identify potential drug interaction can be really difficult because, for example, in exam on polypharmacy, and we will talk about in my first lectures. Assess clinical significance, continue, discontinue, substitute, monitor and follow up, document, communicate with patient healthcare professionals. Role pharmacists in this situation, how to diagnose this possible potential drug-drug interaction or another drug interaction which we discussed before. Be vigilant in monitoring for potential drug interactions, advising patients regarding proper use, and should pay attention on indication, adverse events, contraindication, and doses to prevent overdose. Educate the patient of foods and beverage to avoid when taking certain medication. Advising patient in disease conditions to avoid for avoiding drug disease interaction. Keeping up to date on potential drug and drug food interaction, medication to counsel the patient. Managing drug interaction tips for pharmaceutical industry, for medical doctors, for healthcare professionals, for nurses, for pharmacovigilance specialists, professional drug special pharmacovigilance scientists, pharmacovigilance manager, pharmacovigilance physicians. Learn to recognize factors that alter a patient's risk for and adverse events when exposed to interacting drug pairs. Consider the risk of the potential interaction against the benefit of administering the drugs. If the risk to patient appears to be greater than expected benefit, identify a suitable alternative. Strategies for mitigation harm from drug-drug interaction. First of all, reduce the use of non-essential prescription. Patients are often prescribing drugs that they do not actually need. Prescribers should always set a therapeutic goal first before prescribing a medication and consider non-pharmacology options. For example, when a patient has been diagnosed with hypertension, consider lifestyle option first, diet, exercise, before moving to pharmacology intervention. ensure the patient medication profile is complete, including non-prescription medication. Numerous over-the-counter medication, including herbal products, interact with prescription drugs. Many jurisdictions do not officially record these agents in a patient medication profile, thus unless the patient is interviewed about non-prescription medication or she taken, the drug will not be taken into account when drug interactions are assessed. Separate the administration of conflicted drugs. In many cases, conflicted drugs can be used by the same patient. One of the strategies for minimizing harm in the patient is to separate dose of conflicted drugs. When initiated therapy, start at low doses and increase slowly as needed, titrated dose. The adage start low and go slow is based on the very simple principle: the lower the plasma level of a given drug, the less likely problems are to arise from drug interaction, the will increase the levels of the drug. A conservative approach such as this also allows the prescriber to assess whether an interaction is occurred and whether changes to be made. Initiation therapy with a higher dose reduces the margin of safety for that drug. Use the resources around you. A key point to remember is that given the large and even increasing number of drugs that interact with one another, it is possible to memorize all of other interactions. Clinicians use researchers, typical information technology, to identify interaction and, in some cases, to provide context around the clinical significance of the interaction. Dear colleagues, thank you very much for your attention, and I will be very thankful for your questions, for your comments, and please let me know what topics do you want and do you like and do you prefer that I can include in my future lectures. I wish you everything all best. I wish you all best, and please subscribe on my channel. It will motivate me, and it can be give chance to see all my my potential participant to get in order to get new knowledge. Thank you very much. See you on my future lectures, my dear colleagues.